Depression is not sadness. Sadness is a normal, proportionate emotional response to loss or difficulty. It lifts with time and circumstance. Major depressive disorder is a clinical condition in which a cluster of persistent symptoms, including depressed mood, loss of interest in previously enjoyable activities, cognitive impairment, disrupted sleep, and often physical symptoms like fatigue and appetite changes, persists for weeks or months and impairs daily functioning. Approximately 280 million people worldwide live with depression, making it the leading cause of disability globally. The biology of depression has been mischaracterized for decades by the so-called monoamine hypothesis, the idea that depression is simply caused by low serotonin. Modern neuroscience paints a far more complex picture involving neuroinflammation, stress hormone dysregulation, impaired neuroplasticity, and measurable structural changes in the brain. The monoamine hypothesis emerged in the 1950s and 1960s from the observation that drugs that depleted monoamine neurotransmitters, serotonin, norepinephrine, and dopamine, could produce depressive symptoms, while drugs that raised synaptic monoamine levels had antidepressant effects. The hypothesis was simple, testable, and influential. But it is now understood to be an oversimplification. If low serotonin directly caused depression, SSRIs, selective serotonin reuptake inhibitors, which raise synaptic serotonin within hours, would relieve depression within hours. They do not. SSRIs take 2 to 6 weeks to produce therapeutic effects, a time course that mirrors the timeline of structural and plasticity changes in the brain rather than the timeline of neurotransmitter changes. The neurochemistry matters, but it is not the whole story. A growing body of evidence implicates neuroinflammation in depression. Many patients with depression show elevated blood levels of inflammatory markers including C-reactive protein and cytokines like interleukin-6 and tumor necrosis factor alpha, the same signaling molecules that drive the inflammation associated with infection and autoimmune disease. Inflammatory cytokines cross the blood-brain barrier and affect brain function in multiple ways. They reduce serotonin synthesis, impair dopamine signaling in reward circuits, and activate microglia, the brain's resident immune cells, in ways that damage neurons. The relationship is bidirectional. Depression itself increases inflammation through stress-mediated mechanisms, and pre-existing inflammation increases vulnerability to depression. This helps explain why depression is more common in people with inflammatory conditions like rheumatoid arthritis, diabetes, and cardiovascular disease. The hypothalamic pituitary adrenal axis, or HPA axis, is the body's primary stress response system. When the brain perceives threat, the hypothalamus releases corticotropin-releasing hormone, which signals the pituitary to release ACTH, which triggers the adrenal glands to release cortisol. In many people with depression, this axis shows signs of dysregulation, hyperactivation, with chronically elevated cortisol, or disrupted feedback, where the normal mechanism that shuts off cortisol release is impaired. Chronic elevated cortisol has direct toxic effects on neurons, particularly in the hippocampus, a region critical for memory, learning, and emotional regulation. Suppression of a growth factor called BDNF, brain-derived neurotrophic factor, by chronic cortisol reduces hippocampal neurogenesis, the formation of new neurons that normally continues throughout adulthood in that region. Neuroimaging studies in people with major depression consistently show 2 structural changes, a smaller hippocampus and a hyperactive amygdala. The hippocampus is reduced in volume roughly in proportion to the duration of untreated depression, consistent with chronic cortisol-mediated neurotoxicity and reduced BDNF. The amygdala, the brain's threat detection center, which assigns emotional weight to experiences, shows increased reactivity, contributing to the negatively biased perception of the world that characterizes depression. Effective antidepressant treatment, whether SSRIs, psychotherapy, or exercise, has been shown to increase BDNF levels, stimulate hippocampal neurogenesis, and normalize amygdala reactivity. The therapeutic effect of SSRIs is now thought to depend critically on promoting neuroplasticity, the brain's capacity to form new connections and adapt, rather than simply adjusting serotonin levels. Treatment-resistant depression, defined as failure to respond to at least 2 adequate antidepressant trials, affects approximately 30% of people with major depression. Ketamine, an NMDA receptor antagonist historically used as an anesthetic, was found to produce rapid antidepressant effects within hours in patients who had failed multiple other treatments. The mechanism is distinct from SSRIs. Blocking NMDA receptors triggers a rapid increase in BDNF and activation of mTOR signaling pathways, rapidly restoring synaptic connections that chronic stress and depression have pruned away. Esketamine, a nasal spray form of 1-ketamine molecule, received FDA approval in 2019. Its rapid mechanism illuminated a previously underappreciated truth. The pace of antidepressant effect depends not on neurotransmitter levels but on the speed of neuroplastic change, and neuroplasticity can, under the right conditions, be accelerated.